Well, welcome everyone to our next installment of our Chicago booth, Angels of Texas pitch event. Just a little bit of administrative stuff to go through. So in terms of our timeline today, we're already kind of late. My apologies that the link that came from the university was not working, so we just scrambled to get a new one. But I see people coming in pretty quickly. So we're going to start a little bit late, but we've got enough of time padded into this session that we can give the presenters enough of time to do justice to their storytelling. We'll give them about 15 to 20 minutes to present. We've followed up with 15 minutes of Q&A. You see, in the bar, you'll see a chat and a Q&A. So let's use the Q&A instead of the chat to type in your questions. And we'll kind of compile them and start asking them at the end of the session. And at the end of each presentation, each of the two we're going to do today, we're going to have a quick poll just to gauge interest in a follow-up. And the follow-up is scheduled already for next week. So those of you who say yes or maybe, we will send them a Zoom invite following this session. The two companies here today are Simagent and Blue Star Telehealth. And as my emails earlier mentioned, they're both in the healthcare space. Both of them are bringing in new levels of efficiency in an industry that is quite plagued with a lot of inefficiency, creating significant arbitrage and business opportunities for investors. Simagent is a company in the home dialysis space with a significant amount of momentum, building into their release of their offering sometime hopefully next year. And we've got Steve on, who's the CEO of the company, and his colleague, whose name I don't have, my apologies.
Yeah, Dr. Jim Sloan is our Chief Medical Officer. He's over there waving.
Looks very knowledgeable with those glasses. And so with that, I'm going to hand this over to, I'm sorry, I've got one more slide.
I will leave the glasses on then.
Yes. So just some obligatory information, some information over here. So, while this is a Chicago booth or a University of Chicago kind of event, alumni event, we would also consider people who are not Chicago Chicago alumni, but we'd ask them to go through approval with our board. We typically invest through an SPV. Our SPVs typically invest between $150,000 to $300,000, with people coming on as low as $5,000. Okay. The due diligence, the follow-up, the management, the ongoing management of the SPV, in the ensuing years is handled by our board members. And for that, our management carry is 10%, but we do not charge any other fees, any other administrative fees for the management of this at any time. Okay. So with that, I'm going to hand this over to Steve to present the slides.
Very good. Well, thank you for having us here, Hubert, and thank you for everybody who's both listening live and those who might review this later on your own time. So let me get this in slideshow mode here. Okay, can you guys see my desktop? Hopefully everybody,
yes.
Maybe
yeah, very good.
You can.
Okay, good, Steve, go ahead.
Great. All right. So as Hubert mentioned, my name is Steve Lindo. I'm the CEO and co-founder of Simagent. And at Simagent, we are solely focused on making home dialysis better for kidney failure patients. Our first device in the pipeline is called Archimedes. This is a disruptive device that's going to drastically reduce the cost and the complexity of performing dialysis in the patient's own home. So a little bit of background on our team. I'm one of the co-founders. My other co-founders, Dr. Rick Pendergraft. So my background is really more in systems engineering and mechanical engineering, and Rick's background is more on the electrical and software side of things. But so after doing a brief stint in aerospace and defense, when I was in Dallas, Texas, then I ended up moving up to Chicago and worked for Baxter Healthcare. And they made me the chief engineer on their market leading home choice home dialysis device that generates about $1.5 billion in revenue for them every year. My co-founder Rick also did a stint doing some consulting on the home choice device for Baxter. And then Dr. Jim Sloan, who's here with us tonight, after spending 20 some odd years in academia for University of Rochester as a nephrologist, also went to Baxter, spent about 11 years there, worked for AstraZeneca, so has a lot of experience both in academia and in industry. And at Baxter, they made him essentially the chief nephrologist for their peritoneal dialysis business. And then one of our other advisors, Dr. Raj Malhotra, is another widely respected nephrologist in this industry. So we've got a rock star team that really has a lot of experience in this niche field called peritoneal dialysis. So just to give you a little bit more background, who needs dialysis? So first of all, these are kidney failure patients. So if your kidneys don't work anymore, you got to find another way to remove the toxins. And dialysis is one way to do that. So a lot of people are more familiar with the type on the left here, which is actually not what we do at Submergent. So one method of dialysis is called hemodialysis, where the patient whose kidneys have failed, they go to a clinic, typically 3 days a week. They're hooked up to a machine that removes their blood, filters out all the toxins, and puts the clean blood back in. And of course, it requires access to their arm with a needle. In peritoneal dialysis, which is our focus here at Submergent, this is performed by the patient in their own home at night while they sleep. And there's no blood and no needles involved. Instead, there's a machine that delivers a sugar and electrolyte solution, so think glorified Gatorade, into a surgically implanted port in their abdomen. And you've got this lining that lines all of your lower organs called the peritoneum. And that lining is full of blood vessels, little capillaries. So the toxins that have built up in your blood will just diffuse across the lining and into the sugar water solution. And the machine drains it out. And that's how it removes the toxins. It fills them, lets it sit for a while, drains it out, fills them up again, sits for a while, drains it out. So anyway, this is a therapy that exists today. And the outcomes in peritoneal dialysis are the same or better as they are on hemodialysis. So just to kind of put this in perspective, the market size for dialysis is enormous. Globally, it's about a $57 billion a year spending in dialysis patients. In the US, Medicare spends about $37 billion a year, and that does not count what private insurance companies are also spending on dialysis patients. And then peritoneal dialysis is about $3 billion of that $37 billion today. So another way to put it in perspective is 7% of the entire Medicare budget is going to dialysis patients today, even though they only represent less than 1% of all Medicare patients. So there's just a tremendous amount of money in this field, and it's largely been unchanged for about 40 years. Now, one of the recent reimbursement changes is driving huge growth in peritoneal dialysis right now. So Medicare a couple years ago announced that they were going to change the reimbursement formula to, for once, favor home dialysis rather than in-center hemodialysis, because they found out that this saves them a lot of money, which makes sense. You don't need as many brick and mortar facilities. You don't need as much staff. The patient's doing it in their own home. So they've incentivized the clinics to give them a bonus payment if they can prescribe a lot of home dialysis and a penalty payment if they cannot. So the other reason you're seeing dialysis in general and peritoneal dialysis in particular growing is that people whose kidneys fail, they often fail due to kind of that Western diet of things like hypertension and diabetes can also cause your kidneys to fail as well. Obesity, just an aging population. So peritoneal dialysis is expected to be about an $8 billion market over the next 5 to 7 years. So these clinics, they really want to put more patients on home dialysis or on peritoneal dialysis, but there are some challenges for them to be able to do that. So the first of those, and one of the biggest challenges, is a vexing issue called peritonitis. This is an infection of the patient's peritoneum, and about 18% of PD patients or peritoneal dialysis patients will get peritonitis in any given year. And it's the number one cause for those patients to have to transition over to hemodialysis, which once again, the clinics don't get paid as much if they put those patients on hemo. About a third of PD patients experience excruciating pain during the drain phases of this therapy. And this therapy is going to drain them about 5 or 6 times throughout the night. So obviously that's not ideal while they're trying to sleep. And then one of the biggest complaints that I saw during my time at Baxter was really just around the noise. So almost 70% of PD patients are dissatisfied with the amount of noise that their current PD machine makes while they're trying to sleep. And then, of course, there's the problem of the cost. So I mentioned kind of already, the problem here in the US, in these clinics, these dialysis clinics are very, very cost sensitive. They get a fixed reimbursement from Medicare, regardless of how much it might cost them to deliver the therapy. So they have a strong incentive to try to lower the costs. And then when you look outside the US and you look at it globally, there's about 2.5 million kidney failure patients who will die every year because they can't afford the dialysis machines and the tubing sets and supplies. And then, obviously that makes sense given that, the big competitor in this space, their home dialysis device costs $21,000 as list price. So that's out of reach when you start talking about families outside of the US. So this is where our Archimedes device comes in. It addresses all of those issues. It's up to 70% less expensive than the nearest competitor. We have a connector that we've patented now to connect up to those solution bags that we believe will drastically reduce peritonitis. And then our suction pressures while we're draining the patient are much, much lower, more gentle than the current devices out on the market. And so we think we can drastically reduce or eliminate the drain pain problem, as well as our machine is completely silent throughout the night with the exception of one short click in between filling and draining the patient, and then it's back to silent again. So the patients can sleep as opposed to all those complaints on noise that I saw from from one of the competitors. And then finally, we've made this so much simpler to use. We've got a color touchscreen with graphics and animations that walk the patients through all the setup and troubleshooting steps. Whereas, one of the biggest competitors in this space, they have a text-only green screen display, which is obviously not ideal for a patient, to have to learn how to use this therapy. So to put it from a clinic's perspective, we estimate that clinics can save anywhere between $4,000 to $6,000 per patient per year by adopting our Archimedes device rather than some of the competitors' devices out there. And they can have fewer support staff, fewer nurses, because our machine is so much easier to use than the existing devices and doesn't require them to have to constantly call a nurse, every night when they're first learning how to use the therapy. And then, of course, the cost of the machine and tubing set is less. And so when you talk to clinics, they'll tell you they lose about 11% on every single Medicare patient, and they make it up for it only on their private insurance patients. Whereas if they could adopt our Archimedes device, they can start to break even or even make a profit off of their Medicare patients rather than losing money on those patients. So what you see over here on the left is our proprietary solution line connector. And our competitors are in the middle and on the right. So there are 3 of these connectors on every tubing set to connect to up to 3 bags of the sugar water solution that I was describing before. And the problem with the existing connectors is that once the patient pulls the cap off of the connector, prior to connecting it up to the solution bag, if they accidentally touch the end of the connector, they are touching the fluid path, and that is how they get touch contamination peritonitis. And you see both Baxter and Fresenius have the same problem where the fluid path is exposed. Whereas on Submergent's disposable tubing set and our connector, we recessed the fluid path beneath this shroud around it. So if they accidentally touch the end, they're just touching the shroud and not touching the fluid path, and therefore they won't get peritonitis. And this is what we've already got an issued patent off of this feature. And all the nurses and nephrologists we put this in front of have told us, this should be the standard of care for all PD patients. So a large healthcare company here in the US had conducted a market research study to try to see, would US patients accept a lower cost PD cycler or PD machine? And so they studied all these different features that you see over here on the right. And in the end, our Archimedes device features scored 98% appeal amongst existing PD patients. And I think we scored about 94% appeal amongst current PD nurses. And all the competitors in this space, their features scored high 20s, low to mid 30s appeal scores. So patients and nurses both overwhelmingly preferred our device over the other devices out there on the market. We've also conducted 2 human factors studies to date, a total of 8 patients and 9 nurses. And I won't read off all these quotes, but suffice it to say, the people who've been in front of our device and actually run simulated therapies and programmed it and all those kinds of things really like the features. They like that it can lower the risk of peritonitis. The patients love that our device is mobile within the home because it's on wheels, and it can also operate on battery power for up to 8 hours. Whereas all the other devices, they're stuck in one spot. And, patients, they said, I feel trapped in my bedroom when I use, the competitor's device, because they say, well, look, this therapy is a 9-hour therapy, but I don't sleep for 9 hours. I feel like a prisoner in my room and things like that. So they love the mobility that our device provides. And then the nurses love that our device is so much easier to use. They say things like, this is great. You don't have to have a college degree to use it, because, of course, a lot of our patients aren't like that. In terms of some IP and other barriers to entry, we've got 1 issued patent so far. We've got a number of non-provisionals and PCTs kind of working the way through the pipeline. Those largely revolve around how we're able to get very, very accurate and reliable fluid measurement results by using very, very low-cost sensors. Everybody else who's tried to use these in the past, they break the sensors really easily, and therefore they can't be used. But we figured out a way to make them much, much more reliable and still get very accurate results out of them. Because this is a very tricky therapy, the software algorithms to deliver it are not at all obvious. Our patent attorneys told us to keep those trade secret, because that's what keeps somebody from trying to knock off your device when you think about countries that don't always respect patent protection. And then in terms of some other barriers to entry, when you think of the Baxters of the world, these large medical device companies, they typically acquire their medical devices. They're not designed internally. And indeed, there's examples in peritoneal dialysis and home hemodialysis and in IV pumps where, either Baxter or Fresenius or both have acquired all their successful, medical devices in these spaces. And also these big companies, they've tried a number of times to develop a lower cost PD cycler, and they failed every time where we have succeeded at it. In terms of a regulatory strategy, this is a 510K. We've met with the FDA twice now, and they've told us in writing that we do not need to do a clinical trial. So that really sets us apart from most other medical devices where you worry about a lengthy clinical trial and whether you're going to pass. So we expect to get our 510K clearance in mid-2024 with filing it towards the end of this year. In terms of some competitors, I mentioned Baxter and Fresenius. There's a few other potential competitors in this space. When you think about this joint venture with Medtronic and DaVita, or B. Braun used to be in the PD space, and we've been talking to them again about making the solutions, or Outset Medical. They make a home hemodialysis machine, but their Wall Street analysts are always asking them, when are they going to get into the PD space? So, and of course, we're talking to all these folks. In terms of our business model, this is a razor blades model, and it's a B2B sales model. So we don't sell to patients, we sell to dialysis clinics. We lease the machines to them, and then we sell the single-use tubing sets to these clinics. And we already got, even though we don't have our 510K yet, we already got our first letter of intent from Satellite Health, and which is a top 10 dialysis clinic network in the US. We're also in due diligence with a US company, a European company, and some global strategic partners that are interested in distributing our device around the globe or in other regions. In terms of unit economics, somewhere between $500 to $760 per patient per month, kind of depending on the size of the clinic. And that'll generate about $120 million in revenue within 5 years post-launch. So in terms of fundraising, we've raised about $5 million to date, $4.2 million in an initial couple of rounds of seed financing, and then another $650K in some non-dilutive grants from the state of Oklahoma. And so now we're raising a $1 million priced bridge round. It's a $15 million pre-money valuation. And this will be a priced round, so this will be preferred shares. And really the ultimate goal or usage of these funds is to do all the verification and validation testing to get our FDA 510K clearance. We've already built all the manufacturing tooling, finalized all the design, and all we're waiting for is the funds needed to conduct the rest of these tests. And these are just benchtop tests. There's no clinical trial. Most of the comparable exits in this space have been in about from 200 million to 400 million. But there have been a couple notable exceptions at $2 billion. So Next Stage exited at $2 billion, Outset IPO'd for $2 billion. So it just gives you a sense of how much money there is in the home dialysis space. And by the way, the PD market is 6 times the size of the home hemodialysis market. And these guys were worth $2 billion. So just kind of puts it in perspective. So in summary, we've got a fantastic team that has a ton of experience in this PD space. This is where all the growth is in the dialysis market today. It's all driving towards home dialysis. We've got a device that patients and nurses and clinics and payers all prefer over the existing devices. And we're really addressing what's called value-based care. This overall trend in healthcare towards how can you achieve the same or better outcomes at a lower cost? And we allow these clinics to be able to put more patients on home dialysis without having to hire more nurses because our device is so much easier to use. And so if we can exit at a $400 million exit, as you've seen some of these comps have been, that'll provide a 26x return on investment for investors in our current round. So thank you, and I appreciate your time today and happy to answer any questions you may have.
Excellent. Thank you, Steve. Folks, I'm going to unmute everyone here to allow people to ask questions. So if anyone's got a question, you may want to unmute yourself and ask, but I have a couple of questions while we're doing that. So Steve, help us understand. So you said you have a top 10 dialysis company that shown some intent. How much of the market do they represent, and what will it take for them to start actually using your product and bringing it to their customers?
Yeah, so when you think about, so we're in due diligence with a large, one of the biggest players in this space, to suffice it to say. They have a tremendous market share globally. You're talking, 50+%, 70% of market share. So they're a huge fish in this space. And we are very familiar with all the folks on the due diligence team and know them well. And so they really need something like this. And they've tried several times to develop something like this. So, we think that there's a really strong likelihood of an exit to this large player that we're in due diligence with.
But
and then, of course, go ahead.
Go ahead.
Oh, I was just going to say, of course, we've got a go it alone strategy as well. So if they end up saying, well, we'd like to see a few patients on this device first before we, want to do an acquisition, then of course, once we get our 510K, we'll raise a small round to be able to commercialize the device and just show, with a handful of patients, look, here's proof in the pudding, and these patients really do like our device a lot better, and the outcomes are the same or better.
What about the, them actually using it in trials on your behalf?
Yeah, we've talked to them about those kinds of things, and you don't want to do a clinical trial if the FDA doesn't make you do a clinical trial.
No, I meant like a market trial more than a clinical trial.
Yeah, so that is certainly something that we've been talking to them about, say once we get our 510K, trying it out on a handful of patients. And this is where our letter of intent that we got from Satellite Health comes in, because then, once we get a few of their patients on our device, I think that'll give us kind of that, warm and fuzzy that some people might be looking for if they're very risk averse, to show, look, we've got real patients using this machine. And for us, we feel like it's very low risk because it's delivering the same generic drug that all the other peritoneal dialysis devices are delivering. So then the only question is really around flow rate. And we published a poster at the recent ASN meeting showing that our flow rates were very, very similar to the other devices out there on the market in terms of what their their kind of minimum required flow rate is, and ours was at or very, very close to that. So, we think it's a really low risk that that we wouldn't have good outcomes with our device.
Okay, and I'm assuming they would only take it on after the 510 is cleared.
Yeah, I think so. I mean, the company we're talking to is a very, very risk-averse company. So I think if you look at the other acquisitions they've made, they tend to make them after you've already got a 510K, because then you've taken out all the risk. Sometimes they'll wait until you've got a little bit of patient traction as well. But we think once we get our 510K, that makes us a very attractive acquisition target.
How much of that 1 million has been raised so far, and from whom? Who are the main players so far?
Yeah, so we've already raised $620,000 towards this 1 million. So we've got 380K to go. Most of that has been from existing investors that invested in our previous rounds. So we've got a number of physicians. So I think the lead so far, he's a cardiologist that knows this space, sees these same patients that kidney failure patients tend to also be heart failure patients and things like that. So, he's very familiar with this therapy and knows others in this space. So most of it has been existing investors reinvesting, especially given, once we told them we were in due diligence from a, potential acquirer.
And who are the main investors in that 4.2 million? Are there any funds involved, or is it largely individuals?
It's a little bit of both. So our lead investor in both of our previous seed rounds is an investor that used to be called I2E out of Oklahoma City. Now they've rebranded themselves and they're called Plains Ventures. But so they've invested 1.75 out of the 4.2. So not quite half, but maybe 40% or so. And then the rest has largely been angels. There's a couple of small VCs, a Pathway BioVentures out of Chicago invested in us. But then, mostly others have been angels, as well as we've gotten 4 nephrologists on our cap table that are all part owners in a dialysis clinic. So we only ever pitched it to 4 nephrologists from our previous rounds, and all 4 of them invested.
Anjum, I'm guessing you have a question, so please go ahead.
Sure. First of all, can you hear me?
Yes.
Okay, great. So could you go over the terms of the raise? Is it a safe note, a convertible note, valuation, minimum check size, etc.?
Okay, yeah. So it's a $1 million raise. And like I said, we've got 620K committed already. It is a price round, so it's not a safe or a convertible note. You'll get equity in the company right away with a 15 million pre-money valuation. So, 16 million post-money valuation. And it's preferred shares.
Okay. What's the minimum check size?
Oh, yeah. And given that Hubert mentioned that you guys typically do an SPV, as long as the total amount from the entire SPV put together is at least 25K, that's our minimum. We don't really set a minimum as to what, if you guys want to have that, write a check for at least 25K where, 10 of it came from one person and 50 came from another or whatever, that's fine with us.
Okay. And I guess kind of a bigger picture type question. Is dialysis, I mean, I know a little bit about it, but not like everything. Is this for people who are awaiting kidney transplants?
Yes, with a giant asterisk on that, right? And I'll let Dr. Sloan kind of tell you the realities of transplant numbers here.
Yeah, and again, thanks for asking the question and for making the comment. I feel like I have job security. Anyway, so there are about 125,000 patients in the United States only that come to end-stage renal disease requiring dialysis. And of those, it's actually a pretty small percentage that end up really getting a transplant. Unfortunately, again, there are fewer transplants than there are candidates for transplant. And the additional piece is a lot of the patients just have a number of medical conditions that may make them more difficult surgical/transplant candidates. So again, the numbers of patients that are on dialysis, again, it tends to progressively increase, which again, from this perspective, I mean, it's unfortunately, it's something that patients will need until they either get a transplant or meet their demise.
Okay, so next question. So, I guess you guys know the company Xtherma.
Xtherma?
Yeah.
I'm not familiar with that.
Okay, so what they're doing is they're trying to, I guess there's a certain amount of time that a kidney can be outside of
Yeah.
the body during, before it's transplanted, like 18 hours or something.
Yeah.
Yep. And this is something else, preserve that organ for a longer period of time, I'm sure, right?
Right, exactly. So they're trying to preserve that organ for like 4 days. So, theoretically, if that works, and I know that they got FDA breakthrough treatment last summer, theoretically, if that works, and they've done the trials in pigs, and that worked in a sample size of 100, and I think they're going to human trials either later this year or it could have been late or mid 2024. I guess the question is, let's say Xtherma works, their product works, and kidneys are able, if there's like a 4-day period now, instead of, I don't know, 18 hours, that kidney can be outside the body. Their argument is the number of transplants in the US will dramatically increase.
Yeah, from my perspective, I think if you look at Medicare's goals, so Medicare has stated they're trying to increase both home dialysis and transplant numbers. But I think today the transplant numbers are only like 20 or 25% of all the patients are going to get a transplant, that are on the list. And so even if they bump that up from, let's say, 20 to 30, or, it's still just the rate of growth of end-stage renal disease itself. I still don't think that they're going to move the needle much. But there's been a bunch of other companies who have kind of in that same organ perfusion space, and have all kind of made those same claims, but we really haven't seen any of them move the needle on the number of dialysis patients. The patient count just keeps going up year after year. So I don't think it's going to make a big dent, just given how few organs there are available today.
I'll just kind of add into that, Steve. So again, one, I hope that they're right. That would be wonderful for patients. Transplants come in 3 varieties: living related donor. In other words, a friend, or not a friend, a relative of yours is willing to give you one of their kidneys while they're still living. An unrelated kidney donor, living. Again, number of those are pretty small. Occasionally you hear some events in one city or another where there'll be a swap of some living related donor kidneys, and then cadaveric kidneys. And mainly what we're talking about with regard to Xtherma and preserving kidneys are for cadaveric kidneys. So in other words, somebody died in an accident, or died of cancer of some other organ, and they donate that kidney, or I should say usually it's the relatives that donate the kidney. And that's really where the target is. The problem still is the number of those cadaveric transplants that are available. And that's really what the limiting factor is. Again, I hope that they're successful in what they're doing, and that does increase the number of transplants, but that really is what the issue is.
Okay, thanks.
Yep.
Thanks. Any other questions? We have time for maybe one more question, but do remember we have a follow-on session, scheduled for next Tuesday at 12 noon Central. Okay, so you can bring all your other burning questions to that event. Okay, so with that, I'm going to hand this over to my colleague Alex to kind of do the survey. And Simulgent team, if you're want to stay on, you can stay on, but feel free to drop off.
Okay, I'll probably stick around anyhow, but I always like to hear what other people are into. But yeah, great.
Awesome.
Thank you.
All right. I'm going to launch the poll right now. So all the attendees should be able to see this. Let's see. Launch. And I'll just give it a minute or two for everybody to put in a reply. Anybody who hasn't want to jump in and put in a reply in the last 10 seconds before I close this down? All right, awesome, we're good. So I'll just kind of end the poll. And so next up, we've got Blue Star Telehealth. Blue Star, are you guys, Rob?
I'm here. Can you hear me okay?
I can. Let's see, let me see if I can give you presenter rights. Are you able to share your screen?
Looks like it.
Okay. You can go ahead and share your screen and get started whenever you're ready.
Okay. Hi, folks. My name is Rob Ray. I'm the CEO of Blue Star Telehealth. We are a $3 million company of about 40 people performing in-home telehealth services. We're just outside Washington, D.C. I happen to this evening be at my mother's 87th birthday party down here in beautiful Charleston, South Carolina. So if grandchildren come through that door behind me, it was unrehearsed. Okay. I have a lot of information to go through, but this is a smart group, I have been assured by Hubert. So I'm going to go really fast through a bunch of slides. I'll give you the slides afterwards. And then if questions come up, we can go back and refer to the slide that I flew through too quickly. Okay. And thank you in advance for lending me some of your evening on this beautiful Thursday. Okay, here we go. Can you guys see that all right?
Yes, we can see this.
Okay, strap onto your seatbelts. We're going to go fast. Problem, market, team, sales and traction, financial. And again, this is intended to be sent to people to read. So there'll be a lot of words and don't expect me to go through every one of them. Problem and solution. The issue is that healthcare is moving towards telehealth. And we know that, and telehealth is growing by leaps and bounds. And telehealth, in turn, is moving into the home. The problem is that in-home care requires a lot of non-clinical stuff. An ounce of clinical care requires a pound of other stuff, like hardware and software and shipping and patient training and tech support and repair and all that other crap. And healthcare providers are not good at all that other crap. They're not staffed for it. They don't like it. It's not what they're trained to do. And that's actually slowing down the implementation of in-home telehealth. So the solution is outsource all that non-clinical crap to people like Blue Star. On the left is a provider. On the right is someone at home who has a chronic condition that needs care. And in between is Blue Star. We are all the things that connect that provider on the left with the patient on the right. Nurse monitoring, logistics, software, hardware, and we're actually doing clinical functions according to CPT codes down at the bottom, like remote patient monitoring, chronic condition management, annual wellness visits, et cetera, et cetera. The simplistic way of how it works, and this is a simple scenario, a doctor has 1,000 uncontrolled hypertension patients in her county in Iowa. She gives Blue Star permission to reach out to them. And so Blue Star takes over. We'll market to all those folks. We'll call them up. We'll enroll them as patients if they're qualified. We'll ship and activate equipment. We'll train them on how to use it. We'll manage all the hardware and software and tech support and data flow. We'll monitor their medical results for their hypertension. We'll coach them. And then when they have problems, we'll escalate those issues to the doctor per the protocol that she gave us, because we're operating under her clinical supervision. The doctor, in turn, will take care of those needy patients when Blue Star escalates them to her, and then she'll bill for reimbursement and pay a portion of that to Blue Star. This is a busy slide, but it shows 30 steps in remote patient monitoring. And the takeaway is that we do 27 of them. The doctor does the 3 in red. She approves a patient to be in it. She does the clinical follow-up when they need it. And then she bills, if we're in a fee-for-service environment, for reimbursement. The value prop. To the physician at a hospital, first of all, there's time savings because she's only doing, she's working at the high end of her license, as they say. She can have positive cash flow. She can actually make money per patient per year. Patients like it. Improved outcomes, which I'll show you in a minute. Improved quality scores for her hospital. And improved reputation because patients have indicated that they will move to doctors that provide telehealth. To the insurer in a value-based world, there's cost avoidance, patient satisfaction, improved patient outcomes, and lower churn, which means more money, and improved quality scores, which means more money. Here's 3,000 Blue Star patients that were in hypertension, and they started in the program in uncontrolled stage 2 hypertension. And you can see the reduction in the blood pressures, systolic down by about 10 millimeters of mercury. And the big words in the upper right-hand corner, the result is a 30% reduction in the risk of stroke and heart attack. A busy slide, forgive me. The red is bad. It's uncontrolled hypertension as defined by the American Heart Association. You can see the red starts at 100, and after 6 months, steadies out at about 50%. In other words, half of the people that were uncontrolled became in control. And you can see that the reduction in blood pressure seems to stick. This is a 6-month study. Blue Star is a canary in the coal mine. Our goal is, and this is a somewhat old metaphor, but hopefully some of you will appreciate it. Our goal is to identify problems when they're little before they become big. And another outdated metaphor is spending a penny to save a pound, or spending a penny, I guess, to save $1 now. And that is, let's spend $1,000 a year to control Mrs. Smith's out of control hypertension to avoid strokes and heart attacks. Let's prevent ER visits. Let's prevent preterm births. That's what Blue Star does. Market and competition. The healthcare market is huge. It's, the size of Jupiter and growing. The telehealth market is estimated to be about 25% of healthcare, and it's growing all the time as we find that things that used to be non-telehealth can now be done by telehealth, and the compounded annual growth rates are all high. We are in a little piece of telehealth. We're in-home, low acuity care. So 30 million Americans can use remote patient monitoring. 100 million Americans have hypertension, and 50 million of them, it's uncontrolled. And the same with chronic condition management. Over 100 million Americans qualify for that. And on the right, there's a bunch of statistics about how patients like telehealth. We're riding on 3 waves. The first wave, and I'm a nuclear engineer, so forgive me, I am not a healthcare guy. So forgive me for drawing conclusions from the healthcare industry. But we see 3 big things going on. First of all, telehealth is moving into the home. We think that's an enduring trend. The second is preventative care. It used to be that 50 years ago, actually 20 years ago, we would not pay a penny to avoid Mrs. Smith's stroke, but we would pay a crap load of money to help her after she had the stroke. Well, now the government and payers are coming around and they're starting to pay for preventative care. And then the third is value-based care. It's paying for outcomes, not activity. It's actually paying to reduce hypertension or to improve it, not just to do things towards it. Blue Star is riding all 3 of these waves. Now, a busy slide, and forgive me. There are a shitload, if you'll forgive the French, tools that are software platforms, and they perform a single function. We couldn't list them all on this slide. It would cover up 3 slides. Some of them have hardware, most of them are software, and they do cool things in the home for a single function. There are a few of those providers that provide full service. They do the hardware and the software and the monitoring and the logistics and everything else, but they only do it with their own single tool for a single function. Blue Star is not limited to any one tool or any one function. Our job is to be a full service and tech agnostic provider so that we can solve multiple problems using multiple tools to perform multiple functions. Our primary competition is not some other telehealth company. It's the care provider doing it in-house. In the upper left-hand corner, hey, do we want to do in-home patient services? If yes, do we want to rent tools and do it on our own, or do we want to outsource it? Most of them want to outsource. And if they want to outsource, do we want to have a different outsource provider and a different tool for every single thing in the home? Or do we want a single provider that can do lots of things? If they want a single provider that can do lots of things, then they want Blue Star. Here's actually a slide that we talk with clients about. We have found that people choose us because they like the full service. They like the fact that we're multifaceted. They really like the fact that we are hardware and software agnostic. We're not pitching something that we invented. We're not trying to stick our square peg into their round hole or their triangular hole or their pentagonal hole. We figure out what their issue is, and then we find the best tool for it. We've done this over 8 years and 20,000 homes, customized solutions. We have no upfront costs, no inventory, no long-term contracts, no licenses. And then they trust us because we're a bunch of senior military guys, as I'll get into here in a minute. Not going to go into this too much. There are some barriers to entry. This is very hard work. Our secret sauce is in our back office and delivery. All that said, other people could probably do what they do, or could do what we do. And I'm happy to come back to this slide later if you folks want to. Here's our team. We've been doing this since 2015, 20,000 homes, 42 people, 5,000 families. We've won a lot of awards from the SBA, Small Business of the Year, from the governor, from the Better Business Bureau. We are a military veteran-centric outfit. I'm a retired 2-star nuclear Navy admiral. Our COO is retired Navy. Our chief medical officer, West Point grad, 15 generals and admirals on the advisory board, 44 generals and admirals from all the services as shareholders. We're certified by all those veteran-based certifications there on the right. Here's our very good-looking team. Our chief medical officer, West Point guy, neurosurgeon, 2 combat deployments in Iraq, and then he managed all of the PTSD telehealth programs for the Army. And in the lower right-hand corner is the aforementioned advisory board of doctors and nurses from the Army, Navy, Air Force, Marine Corps, and Coast Guard. A smart, small board, healthcare CEO, head of strategy at a very rapidly growing telehealth company, an Accenture global partner, 3-time CEO with exits, including exits to Microsoft. And then Mark Sandler is a career banker in monthly recurring revenue businesses. We have expertise in business execution. I and Dave Sween and Dave Rich all ran organizations with thousands of people and billions of dollars in revenue. We have healthcare domain experience and we have startup experience. 78 veterans as investors, 44 of which are admirals or generals, and 6 of which were presidential appointees. Growth. Here is our sales team. We have a classic sales process with a funnel, generating leads, letters of intent, signing contracts, a standard go-to-market strategy. We generate leads in normal ways. Our targets are large physician groups, federally qualified health centers, hospitals, and payers. And we're working through Vizient. We're on the Vizient GPO contract. The NACHC is the National Association of Community Health Centers. We work a lot of conference channels. This is my feeble view of the healthcare industry. We started with doctors' offices. We moved to clinics, and we're in clinics and hospitals, and now just starting work with payers. We want to move up into the Mount Olympus range of payers because we believe that healthcare is moving towards value-based care, and that's where we want to be. Here's our traction. We tripled in revenues in 2022. We from about 100,000 to about 300,000 in revenue, and we expect to have at least double again this year and double again next year. We have some really big fish on the line. The Veterans Administration, we just won a $125 million contract with them, which I'll tell you about in a minute. United Healthcare, Highmark, which runs Medicare programs and Blue Cross Blue Shields in 5 or 6 states. Vizient, the world's largest GPO. We're starting to talk to Indian Health, et cetera. The VA, we just won this week. This is a brand new, fresh slide. No humans have ever seen this before you guys did. The contract for the VA was remote patient monitoring for 100,000 veterans for 8 years. It's a $1 billion contract. They're giving $250 million to 4 different awardees, which is about $30 million per year per awardee. Our prime was Valor Healthcare of Texas. Valor is a very well-established company that does about $150 million a year in VA work, operating community-based outreach centers and treating about 150,000 veterans monthly. We are the RPM sub on the team. And since this is an RPM contract, we'll get approximately 50% of the revenue. That'll end up being about $50 per patient per month. This year, we just got the award earlier this week. I'm headed out to Denver to talk to the government on Monday. So in 2023, we'll be building and installing the systems. In 2024, we'll ramp up the patient count, and hopefully we'll be at full revenues in 2025. The government said, do your costing based on 18,000 patients. So you can see that the fees to Blue Star would be on the order of $15 million a year at 18,000 patients. The government wants to grow the program, so we're hoping that we can actually move north of that. Almost done, gents, and then I'll shut up and you guys can hang up, or we can talk about whatever you want. Our revenue model, we are tech-enabled services. We are using a bunch of different hardwares and softwares. We add labor and program management to deliver in-home services. In the fee-for-service world, we perform the duties of a CPT code, and then the provider bills. Provider gets X and pays us 1/2 X, or just rough numbers. In a value-based world, we perform a service, and the payer just pays us, but the payer expects to save 2X or more in avoided cost. Here's our growth over the last 15 months. You can see that our EBITDA continues to be about $50,000 a month negative, and we're working hard. We expect that once we get up to about 375,000, that we'll in revenues, that we'll have break-even EBITDA. Here's our numbers. We finished 2022 at $2.2 million in revenue, but at a $3.3 million run rate. We expect to finish 2023 at $4 or $5 million in revenue, but at about a $7 million run rate. These numbers do not include the VA win. This slide was made before Tuesday, and so I just haven't put the VA win in there. We like to think that the VA win will increase these numbers significantly, since we think that in 2024, we'll have $11 million from this telehealth and then $15 million from the VA. So I got to update this slide. We have a data room with a crap load of stuff in it, 150 different documents. It's all available to you. And next to the last slide, we're asking for $1 million in convertible debt as a bridge to an A round later in 2023. We've had 500 of this funded already. We're looking for the second 500. Our last equity round was at 24 million pre-money, and our terms on this convertible debt is 9% interest, either paid or accrued. It's a 20% discount to the coming round. We'll be asking for at least 28 million pre-money in the coming round, and it's got a cap of $20 million. Investors include Ziegler Linkage out of Chicago, Driehaus out of Chicago, Composite out of DC, and a number of family offices, and the aforementioned 78 veterans. Last slide. We like to think that we're showing proven traction in a rapidly growing market. We have multiple revenue opportunities. We're working value-based payer contracts, fee-for-service contracts, and now the VA contract. We have a clear path to liquidity. Our goal is, frankly, to get, and I must have missed this slide, our goal is to get to, say, a $20 or $25 million run rate, which we think is 24 to 36 months away, and then to sell the company to a strategic investor that needs what we do. We have an experienced, seasoned management team who has gray hair and who has grandchildren lurking in the background. And we've, not only are we old chronologically, but we have a lot of experience that I didn't go through because I was talking too fast. And then we have a kind of a military dedication to the mission. We are all about taking care of patients, number one, taking care of staffs, hospital staffs, number two, and then taking care of shareholders. We live close to the vest. We've been around for a while. We still live on $30 folding plastic tables from Home Depot. And so this guy, Grant Chamberlain, is in charge of healthcare M&A at Ziegler. He said, telehealth is exploding, RPM's exploding faster. It's white hot, and it's about trust and delivery, which is why caregivers are looking for a trusted player like Blue Star. We did not pay Mr. Chamberlain to write this. He wrote it in a report, and we got his permission to include it here. So I will quit talking and thank you very much, Hubert, for the opportunity to present to the gang. And now I'm ready to answer questions for as long as y'all want. Over.
Hey, Rob, great presentation. Lots of information there. If anybody has any questions, feel free to raise a hand or jump in. But I've got some questions that I can start out with. In terms of the revenue model, where does my question is kind of, where does the profit come from? Is there profit that Blue Star makes off of the hardware devices as well, or is it primarily service?
It's a good question. And so we are essentially renting software and using it and charging software fees. So we have a markup on software.
Okay.
We are employing labor and charging more than the labor costs us. So we have a markup on that. With our customers, sometimes we sell them the hardware, which has a small markup, but oftentimes we'll just charge them a hardware fee. It's kind of like leasing a car, but not quite, because they don't own the hardware. We'll charge them a hardware fee. And so we earn money on that. So the margins for the federal work, for the software, for the human labor, and for the hardware is, they're all different, as one can argue, and as one could see. And we expect to have about a 40 or 45% gross margin on telehealth services between hardware, software, and labor.
Got it. And then let's see, I didn't see any hands. So I'm just gonna keep going until somebody else wants to jump in with questions. After Blue Star acquires a patient, how long do these patients generally last? I'm assuming the maternal patients, it's up to delivery, but what's the average lifespan of, or what's the average kind of timeline that a patient would stay with Blue Star Telehealth?
Our contract for maternal patients, surprisingly, is 12 months. We're trying to catch them at the 3-month point and have them 6 months prepartum and 6 months postpartum. I did not know this until we got into it, but the United States has the worst maternal mortality rate among first world countries. And most of that maternal mortality occurs after birth, not at birth. And so those are 12-month contracts. Back to your original question. We're experiencing an organic attrition rate of 2.1% monthly. Okay, that's organic of active patients. So if we sign up 1,000 patients and they are actively measuring their blood pressure or whatever, we're experiencing about a 2% attrition monthly. So we don't know how long the average person stays, because that's actually a hard calculation to do. And we've only been doing this for a couple of years.
Okay. And the attrition, is that primarily being driven by the physician saying they no longer need it, or the treatment's over? Or?
No, I think most of our attrition is due to weariness on the part of the patient. Sometimes the patient change statuses. Sometimes they go into a nursing home. Sometimes the physician does say they don't need it anymore. But the people that we're taking care of have chronic conditions, and the definition of a chronic condition is something that you're just going to have forever. So we're not oftentimes seeing physicians saying, "Okay, Mrs. Smith, your blood pressure is better. We're taking you off this program." That isn't typically happening.
Okay, thank you. Hubert, did you have a question to jump in with, or should I just keep running? Because I've got a bunch.
Actually, I do have a couple of questions. So help us understand, $50 per patient per month. I'm assuming you're touching them at least once a month. What sort of margins are we looking at on that $50?
Okay, I'm sorry. The $50 per patient per month for the VA includes no monitoring labor on our part. The VA nurses are doing the monitoring.
What are you getting the $50 for?
We're getting the $50 for operating a call center for tech support and customer service, and for providing software.
Got it. So the service is provided by the primary, so who's providing the service, Robert?
But so think of the service for remote patient monitoring as three components. There's actually a few more, but the three biggies are software, hardware, and human nurse monitoring. Okay. All of our clients are paying for hardware, software, and nurse monitoring, except for the Veterans Administration. They are doing their own nurse monitoring.
So you're providing the infrastructure for them to be able to do that.
Yes.
Okay, and so what are the margins on that?
It is a good question, and I would say we haven't started the contract yet, but I would say that they're going to be pretty narrow government-ish margins, probably, a gross margin in the 20 or 25% range.
Okay. I'm assuming it'll take about a year to ramp up to that full capacity at least.
Yes.
Okay. The other question is your main business, however, other than the VA agreement, comes from using your infrastructure to provide a service, an ongoing service where your people monitor, do the monthly monitoring, right?
Yes.
Talk to us about those revenues. How does it break down per patient? What are the margins over there?
The margins are not constant because they depend on the service that we're providing. But our margins, if you look only at the labor component, only say for hypertension, our margins are probably 30% on the labor component. We're now providing 24/7 contracts for maternal health. And so our payments there, instead of say $70 a month, are more like $125 or $130 a month. And so the margins there will be greater. So the labor margins are tough. The toughest part of this business, frankly, is providing the labor to do the monitoring for these tools, which is why so few other people in the industry do it. It's the hardest part. It's also not that it's a secret sauce, but it's a differentiator for us because every clinician that we've run into does not want to add staff to manage these programs. They want somebody else to do it. They don't want to buy a tool. They want to buy someone that just performs the functions with the tool.
Got it. I'm out of questions at this point because I know I did ask you other questions earlier.
In terms of providing the tool, have you ever has your team ever considered working with home healthcare providers? And so the reason I asked this is I was speaking with a friend of mine who is in the home healthcare business, and so they send out nurses or aides to go to people's homes that have chronic health conditions. And I asked them, I go, hey, have you guys ever looked at remote patient monitoring? And they said, yeah, absolutely. This is something that we want to do. We couldn't figure out how to. And I said, okay, great. But what about your competitors? Are they doing this? And they're like, they can't figure out how to do this either. Is this a potential? Has your team ever looked at this as a potential avenue for acquiring customers?
Yes, we have. We're working with one outfit in Oklahoma. We think it's a fertile market. And the classic situation, the home healthcare provider, they have a doctor or an NP who can order healthcare, obviously. They have an NPI number so that they can bill, and they have patients. And the patients have chronic conditions. So yeah, tell your friend that the whole concept of Blue Star is that they could literally say, here's 40 patients that need remote patient monitoring. We do the entire thing. And all they have to do is bill at the end of the month and pay us half of what they collect. And I say half in an approximate way. So we do believe that that's a fertile market. It's not as fertile as the payers because home health doesn't have as many patients. We're looking for people that have thousands of patients. But yeah, in the meantime, we're if you know of anybody, we're all ears, and it's a perfect fit.
Yeah, it's compared to the payers, I think home healthcare is pretty fragmented. So
Yes,
they're not going to come with 10,000 potential patients.
right.
So I had a question around setup. When you have a new patient and let's say you send them the equipment, what if do you ever run into issues where they're having technical difficulties getting set up via kind of telephone or video coaching? And how do you address that if they're not local?
We've done this about 20,000 times, and we're pretty good at doing it over the phone. If we can't accomplish it over the phone, we typically ask for an adult son or daughter to help, because typically this is a senior population. We've never had a problem with a 40-year-old knowing how to do it. And then if there is no son or daughter available, we ask about a neighbor, or in the case of home health, when the home care provider is in, either home care or home health provider, we ask them to help. We have the worst case scenario, which we've done maybe 5 times in 5 years, is we can send a tech to the house. But we just don't like to do that because, frankly, some unknown tech knocking on the door and saying, "Hey, I'm from Blue Star," that'll freak out any person who is so old that they can't figure out how to do this on their own.
Yeah, makes sense.
Robert, my wife had a patient the other day, and the patient was basically, my caseworker from, I'm not sure whether it was Aetna or United Healthcare, was asking me these questions, telling me to do this. And my wife said, "Who the heck is that?" Okay, so she wasn't even aware of this. So it sounds like some of the large payers already have these kinds of resources. How do you kind of, break into that market, or how do you kind of compete against those, or are they a completely different offering?
Everyone has care coordinators. Well, I mean, that's sort of a generalized statement, but every big payer outfit has care coordinators. We haven't run into a single payer outfit yet that has a shop that delivers RPM or CCM into the home. Here's an example. 2 examples. United Healthcare of Tennessee, they have a Medicaid contract for 350,000 lives, and they have 72,000 dual eligibles. And they have a few people that have just terrible diabetes issues, and it's screwing up United Healthcare's scores, which is screwing their quality scores, which is diminishing the reimbursements that they're getting from the government under their Medicaid contract. Those hundreds of problematic diabetics belong to dozens and dozens of providers. So United Healthcare is hiring us to provide a service to those diabetics, and we'll do it in concert with their providers. Highmark Whole Care is in Pennsylvania. They have 300,000 Medicaid lives. Their problem is maternal mortality. Pregnant women with who are rural, who aren't going to their doctor's appointments, pre-existing conditions like obesity or hypertension or diabetes. And so in this case, Highmark is having us work with the providers to work with the patients to improve outcomes. And it's good for the patient, it's good for the provider, and it's good for Highmark because ultimately they'll save money. So there is no, and Highmark has its own set of care managers, but the care managers can't do what we do. We're working in concert with those care managers. So it's a really interesting point, and I'm sure I didn't completely address it, but we recognize that there's a lot of people out there trying to help these problematic patients, and we're trying to do it in concert with those people, not in some conflict with them.
But to me, it sounds like each of these deals requires a fair amount of customized processes to be developed and put in place.
Is that a question?
Sure, I guess. Yeah, I mean, I guess it's just a yes, no answer.
Our processes for enrollment are relatively uniform. We have different scripts and things like that. Our processes for onboarding, for shipping, for monitoring. When we customize, for instance, we have a customer in southern Mississippi, and a very senior population, not technically skilled. And so we use different hardware and different software for them than we would for, say, pregnant women in Pennsylvania who are all in their 30s and 40s. We can give them a tablet and have them Bluetooth. We can use apps and text-based solutions. We can't do that in Southern Mississippi. So the hardware and the software that we choose are customized. The scripts and things that we use are customized, but the basic game that we're playing, the basic process doesn't change.
Got it. Thank you. That's helpful. Back to you, Alex.
I only have one question left. I'm curious just to see what your take on this is, Rob. I'm sure there were a number of different factors, but in 2022, the number of customers or patients basically ramped up by 10 times. What was the primary drivers that caused that?
In 2021, we were generating leads and knocking on doors and signing up federally qualified health centers and hospitals to be clients. And there's a certain onboarding process in the same way that when you plant a flower, you kind of have to water it and fertilize it and wait a while, and then suddenly it will bloom. And all those things started to bloom in 2022. Yeah, we're in 23 now. They all started to bloom in 2022. So the rapid growth there was the result of seeds that we planted in 2021.
Got it. That's that's the last question that I have. Is anybody? Oh, there's a question that came through the chat. So this is from Vinod Patel, and the question is payer reimbursement only through existing CPT codes that HCP would have used in the past, or is this reimbursed as a separate service?
There are dozens of CPT codes that we can perform in the home for telehealth. Remote patient monitoring, chronic condition management, principal care management, transition care management, remote therapeutic management. There's lots of them. So when we engage with a client, the client says, here's the codes I want you to perform. And then we run a cash flow. We figure out what percentage of their population is reimbursable, and we do all the math to make sure that the program will be viable for them. So that's all in the fee-for-service world. We're only working with existing CPT codes. So okay. I'm not sure if I answered that question or not.
Vinod, if that does not answer your question, feel free to jump in. I'm not seeing any other questions. So, Rob, I really thank you for the time. I'm going to launch a quick, Vinod said it did answer his question. So yes, thank you, Rob.
Thanks.
So I'm going to launch a quick poll, and Rob, you can drop off. We really appreciate the time, and I'm sure we'll be in contact soon. So yeah.
Great. Thanks, guys.
Right.
I really
Thank
appreciate your time. Have a good evening.
Yeah. All right, guys. I just launched the Blue Star Telehealth questionnaire. I'll give it a minute to run. Okay, and that's that. Hubert, did you want to say anything and close out? No. All right, guys. So we will be in contact with the next steps and follow-up meetings. And then other than that, I want to we appreciate everybody's time, and yeah, have a great evening, guys.